Okay, this lecture is about evaluation of the lower urinary tract symptoms. And before we start, I just give you some information about the pathophysiology of micturition. So, how you actually pass urine, or how your bladder is functioning. Now, the bladder is like a bag of muscles. This muscle is called the detrusal muscle. It's connected with two pipes to the kidneys, and also it has pipe which goes outside called urethra, through which the urine pass out. The kidneys producing urine all the time, and the urine is dribbling inside the bladders all the time from both ureters, but you don't feel anything in the bladder. The bladder continue to fill until you reach about 150 to 200 ml. When at this level you start feeling that there is something in the bladder. Now, this bladder actually, as we said, has a wall which is a muscle. This is called the detrusal muscles. During this filling stage of the bladder, the detrusal muscle stays relaxed. It also have some valves at the neck of the bladder and external urethral valves. These also are closed, so during the filling stage of the bladder, no urine will be leaked out. How this happen? There is signals sent from the brain to the spine. The spine has parasympathetic nerves originated from S2 and S4. These nerves are responsible for contracting the detrusal muscle. There is also sympathetic innervation of the bladder, which cause relaxation of the detrusal muscle and contraction of the bladder neck. So the parasympathetic system will cause contraction of the detrusal muscle. The sympathetic cause relaxation and closure of the bladder neck. The somatic innervation of the bladder, the pudendal nerve, excitation of this cause contraction of the external urethral sphincter. So it closes the urethra. So during the filling stage, your bladder tell the parasympathetic system to relax, so it will not cause contraction of the detrusal muscle, and the sympathetic system to stimulate, so it keeps the detrusal muscle relaxed and the neck bladder closed. Also, it tells your pudendal nerve to keep the external urethral valve contracted, so the urethra is closed. So you reached this level of 150 to 200 ml. You start feeling that there's something in the bladder. This is called the first sensation. After that, your bladder continue to fill until it reach 400 ml. At this level, you feel that you need to go to the toilet, but you still can hold it. So your brain still signals to parasympathetic, sympathetic, and somatic to keep the bladder relaxed and the valves closed. So sometimes you are in lecture, you feel you need to go to the toilet, but you can hold it. You are at the level of about 400 ml. After that, it continues to fill. If you reach 600 ml and above, you need the urge to go to the toilet. You have to go to the toilets. Okay, so when you go to the toilets, what happens? You sit in the toilet seat. Once you want to start urination, the brain will send signal to the parasympathetic system to relax, to contract the detrusor muscle, and send signal to the sympathetic system to open the valves, the bladder neck, and to the pudendal nerve to open the urethral valve. So the detrusor muscle will relax, the pipes will open, the valves will open, and you will push the urine out. This is how you urinate. So, if we have symptoms from the bladder or the urinary symptom, we divide them into stages according to the micturition. So, we have the storage symptoms, which are symptoms during the storage phase. You might have urinary incontinence, which basically it's involuntary leakage of urine. We might have urgency, which is a sudden compelling desire to pass urine, which is no way you can differ it. You can have frequency, nocturia, nocturnal enuresis. We can have urge incontinence, which is involuntary leakage of urine, accompanied or immediately preceded by urgency. We can have stress urinary incontinence, which is involuntary leak of urine from the urethra, which is usually associated with increased intra-abdominal pressure due to any reason like sneezing, coughing, straining. You can have mixed urinary incontinence. In this lecture, we'll concentrate on the urge incontinence and stress incontinence. Also, storage symptoms are continuous urinary incontinence, other types of incontinence, voiding symptoms when you are voiding, either slow stream, intermittent stream, hesitancy, which is difficulty initiating micturition, or straining to void. Post-micturition symptoms, feeling of incomplete emptying of bladder, and post-micturition dribble. Now, the overactive bladder, this is a syndrome which can be expressed by either urgency with or without urge incontinence, usually associated with frequency and nocturia. There's many terms for this syndrome. Some people call it overactive bladder syndrome, urge syndrome, or urgency frequency syndrome. If you see this picture, this lady is running to get to the toilet. These are sweating, so it's not urine. So this is urgency. If you see these drops coming down between her legs, then she's leaking. Then this is urge incontinence. Epidemiology of urinary incontinence depends on the age, race, pregnancy, childbirth, and menopause. There's many types and causes of incontinence. We'll talk in detail about urinary stress incontinence and detrusor overactivity. We have also overflow incontinence, fistula, congenital, urethral diverticulum, other types due to infections, etc., and functional due to immobility. So how we assess the lower urinary tract? As for anything or any disease or any patient, we start with history. So talk to the patient, ask her about the symptoms, how she leaks, when she leaks, what makes her leaks. Examine her. You might find obvious cause which explain the symptoms, like if you see this picture, massive mass in the abdomen, This what caused the urinary symptoms. If you see this vaginal examination, we have a massive cystoceles. So no wonder this lady suffer from urinary incontinence or stress urinary incontinence. Neurological examination, patient mobility and mental state, incontinence-associated dermatitis, vulval and vaginal atrophy. You should look at all these things as well. Imaging, you might find a mass pressing the ureter, the bladder, like this fibroid mass. It could be a fibroid or it could be a mass in the bladder. Can't tell from this picture. Investigation, the basic investigations, which is the most important thing for you to start with, is urine test, simple urine test, because infection is a common cause of incontinence. It's very easy to find, very easy to treat. Bladder diary, ask the patient to write her symptoms, when, how she had the symptoms, what she was doing, what she was drinking, and see her after a month. So you'll have more information about the bladder. Pad test. We will explain that in a bit in detail. So basically is you weigh the pad before the test, then you ask the lady to drink water, then give her some exercise to provoke bladder. Then after that you weigh the pad after the test and see if there's difference on the weight, and we'll explain in details in another slide. Advanced investigation like conventional substrate cystometry, video cystourethropy, ambulatory urodynamic monitoring, urethral pressure profilometry, imaging study, cystourethropy. From these, we will explain in detail the urodynamic study. Now, basic investigation, urine test, bladder diary, and pad test. This is the urine test. Bladder diary, why and how, we'll mention that. So this is example of bladder diary. There's the time, the bathroom trips, leaks, what you are doing, if you have urgency, the type of fluids and food you had. Pad test, objective, non-invasive. We can have 1 hour pad test, 4 hours, 12 hours, 24 hours and 48 hours test. The 1 hour standardized test is weigh the pad, drink 500 ml, rest 15 minutes, moderate exercise for 30 minutes, then 15 minutes provocative exercise. It's positive if you have more than 2 gram difference in the weight. It's severe if you have more than 10 gram. Urodynamic study. It studies of lower urinary tract function and dysfunction. Basically, you simulate the function of the bladder by filling the bladder, and see how it behaves when it's full with urine or with fluids in this occasion. Why we do urodynamic? Because the bladder is a poor witness. There's poor correlation between the symptoms and the clinical diagnosis. So then don't rely on the bladder symptoms, because correct diagnosis equal correct treatment, especially distinguishing between stress urinary incontinence and overactive bladder, because stress incontinence, the treatment mainly surgery, overactive bladder, the treatment is mainly medical. And consequences of inappropriate treatment, if you treat overactive bladder, for example, with surgery or thinking it's stress incontinence, you might deteriorate the symptoms. So the urodynamic studies, it's basically 3 stages: the free flow study, the filling cystometry, and the voiding cystometry. So the patient comes to the clinic, she goes here, for example, it's like a toilet. see she urinate and all the urine comes here. So you measure the amount and the flow of the urine and the speed of the flow. Then the next stage is she comes to this room, she sits on the gynae bed with leggings here. Then you put a catheter in the bladder, a catheter in the rectum, and you connect them to a monitor. You also put a catheter in the bladder to fill the bladder with normal saline, and you start filling the bladder and recording the behavior of the bladder through the monitors of the catheter in the bladder and in the rectum. Once you fill the bladder, you ask the lady to stand up, to cough, to sneeze, maybe to jump, and see if she leaks. So the Euroflow meter, the first stage one, it's simple, non-invasive, voided volume and flow rate. The peak flow is more than 15, this is the normal study, more than 15 mil per second. She should void more than 150 mil, and the residual volume should be less than 100 mil. Residual volume is the urine left in the bladder after you finish urination. Usually there is still amount of urine stay there. It should be less than 100 mil. Filling system, retrograde filling of the bladder, filling, okay, we said that. This is the normal Euroflow meter. It's like normal distribution curve. So the flow started, reach a peak, then go down, then stop. Here we have the trouser under activity. You can see how the curve, and here you see straining to pass urine. This is a normal urodynamic study. We have here pressure vesical, pressure abdominal, and pressure detrusor. So the vesical pressure is measured by the catheter inside the bladder. The abdominal pressure measured through the catheter in the rectum. The detrusor pressure is the difference between these two. And you can see here, here we fill the bladder with saline. So you see the amount of fluids also written here. And here we ask the patient to cough, and we see if the patient leaks. So you'll see on the urodynamic study, for example, cough, and you see leak here. Or if you have, for example, overactive bladder, you'll see suddenly here, sudden contraction of the detrusor muscle with leakage of urine. So you'll see here a peak of the detrusor muscle, then you see leakage of urine. While in stress incontinence, you'll see leakage with cough without change in the pressure. Okay. So, voiding systometry, pressure flow study. If you have obstruction, you'll have high detrusor pressure, more than 50, with poor flow. If you have underactive detrusor function, then you'll have low detrusor pressure, less than 20, with poor flow. Urodynamic diagnosis. After urodynamic study, you can diagnose overactive bladder or overactive bladder with incontinence, detrusor overactivity incontinence. You can have urodynamic stress incontinence or genuine stress incontinence, or you can have both stress incontinence and overactive bladder. There's other complex investigations, video cystourethropy, ambulatory urodynamic monitoring, urethral pressure profilometry, imaging study, bladder wall thickness, MRI, voiding cystourethropy, and cystourethropy. Here, this is diverticulum, this is trabeculation, ureteric reflux, imaging study, bladder wall thickness, upper renal tracts, MRI. What we have here, IVU, which showed double ureter here, double ureter on this side. This is cystourethropy or cystoscopy. Cystoscopy is very important investigation where you put camera through the urethra and you examine the inside of the bladder. You can use rigid cystoscope or flexible cystoscope. This is the picture inside the bladder. You can see here diverticulum, tuberculosis, stones, and this is a lesion where you can take biopsy. Treatment of stress urinary incontinence and overactive bladder. So, treatment of urinary incontinence, general consideration for all types. The most important thing you need to know when you're treating incontinence is the treatment aims is to improve the quality of life of the patient. It's not treating life-threatening situation. It's not life-saving procedure. So some patient might just need counseling and they are happy with no treatment. Anyway, lifestyle modification, fluid intakes, caffeine, tea, coke, weight reduction, smoking. Basically, lifestyle modification. Avoid anything that irritates the bladder, like pops, Coca-Cola, Sprite, 7-Up, etc. Caffeine, tea, overweight, and smoking. Pelvic floor exercise, muscle training. So, if you want to classify the treatment, it's classified into conservative, medical, and surgical. Okay, conservative. It's useful in women who are not fit for surgery, have not completed their family, breastfeeding, or they are less than 6 months postpartum. Conservative measures include pelvic floor exercises, biofeedback, electrical stimulation, vaginal cones, and urethral devices. 100 of devices. You can use any, but the most famous one in the market are the ring forceps and the shelf, the ring pessary and the shelf pessary. Pharmacological management, duloxetine. Duloxetine is a serotonin noradrenaline reuptake inhibitor. It enhances urethral striated sphincter activity via centrally mediated pathway. So it makes you happy and it makes you continent. So it significantly decreases the incontinence episode. The problem with this, it needs about 4 weeks to start working. 25% of the case cause nausea. It's good in women who's waiting for surgery to relax them a bit before surgery. It acts or it's better if you give it with pelvic floor exercises. The surgical management, there is many procedures we can do for stress incontinence. The first procedure offers the best chance of cure because you are working in virgin anatomy. Mid-urethral theory or integral theory. Well, this theory is about the supporting the middle part of the urethra. The concept is the maximal urethral closure pressure is at the mid-urethra. Damage to pubourethral ligaments impair mid-urethral support. Mid-urethral procedure have largely replaced colpus suspension. So basically the theory in managing the theory behind surgical management of this part of the urethra is to support this part more because this would support the urethra and prevent from leaking when the intra-abdominal pressure increased. So how we support this? By putting tape under this, or correcting or the fascia under this part, strengthening the fascia under this part. So when there's intra-abdominal pressure, this part remain steady in its place, doesn't go down and allow leakage. Surgical management, colpus suspension, suburethral tapes, and urethral bulking agents. Mid-urethral tapes, there's two types of tape, transobturator mid-urethral tapes and transvaginal tapes. Bulking agents, it might be useful for old women who cannot tolerate surgery, or for women who underwent many operations before. The outcome, cure rate 50% and subjective improvement 70%. Basically we have these agents and inject them in these sites. Now, what's the recommendation for the treatment of stress urinary incontinence? First, pelvic floor exercise for at least 3 months. If no improvement, you can move to retropubic tapes. If there's no improvement, you can use colpus suspension, which is another operation where you put stitch on the vagina on both sides of the urethra, and you lift this and stitch it to a ligament in the pelvis to hold the urethra, to suspend the urethra up. This might prevent leakage. Bulking agent or anterior repair. Now, anterior repair used to be a type treatment for stress incontinence, but it has a high failure rate and it's not recommended for treatment of stress incontinence. However, recently this operation is coming back, and some people recommend anterior repair in the first instance, especially for people who have cystocele. Wait for a period of 3 months. For some people, wait for 2 years. If no improvement, then you go and put a tape. The other school is with repair, you put tape straight away. So key points: conservative management should be for prior surgery. Duloxetine may be used in conjunction with pelvic floor muscles. Mid-urethral tape is the operation of choice in the primary continence surgery. TVT and TOT procedure have similar success rate. Urethral bulking agent offer alternative approach to continence surgery. Overactive bladder. Now the treatment again is conservative. Advice regarding fluids intake. So if you are drinking too much fluid, restrict that to 1 to 1.5 liters per day. Avoid anything irritate the bladder like caffeine, alcohol, pops, etc. Bladder retraining. Bladder retraining is basically pass urine by clock. So train your bladder to hold more. That's the idea. So regardless if you have urgency or not, you pass urine at, for example, 9 o'clock, then at 10 o'clock, 11, 12, etc. Even if you are not, if you don't have the desire to pass urine. Now, after that, couple of days of this, then you go 2 hours. So start at 9, then 11, 1, 3, etc. Until you reach 4 o'clock, 5 o'clock, then you train your bladder to hold and you pass like a normal times, up to 7 times during the day is normal. Pelvic floor muscle training. Pharmacological training. There's no specific drugs that act on the bladder and urethra which do not have systemic side effects. That's the problem with all the medication for overactive bladder, the side effects. And the side effects are dry mouth, constipation, blurred vision, insomnia. You can use oxybutynin, tolterodine, sulfanicin, daraphenocin, tropsium, and physotherapy, but the first choice and the cheapest one is oxybutynin. As we said, all these are anti-muscarinic drugs. These are the advantages and disadvantages. All of them have similar efficacy. The problem with the side effects. Another new drug is B3 agonist. It's not anti-muscarinic, which means doesn't have the side effects of anti-muscarinic. We use it 50 milligrams single dose a day. If you have a problem with liver or kidneys, 25 milligram. This is trade names. Another option is intravascular therapy with botulinum toxin. Neuromodulation is another modality of treatment of overactive bladder, stimulation of peripheral nerves, which might affect the continence of the bladder. It's invasive and expensive model of treatment. Posterior tibial nerve neuromodulation. The outcome of neuromodulation is more than 50% reduction in urinary symptoms, 46% completely cured. Surgical management. As we said at the beginning of this lecture, that the overactive bladder treatment is mainly medical, but there is 10% remain refractory to medical and behavioral therapy. In these cases, you might need to do surgery. The type of surgeries we do for overactive bladder are augmentation or clamp cystoplasty, clamp cystoplasty, or autoaugmentation, or detrusor myomectomy, or urinary diversion. You divert the whole, divert the urine to the bowel. So, what are the recommendations in treating overactive bladder? We start with bladder retraining. If there's no benefit, we move to antimuscarinic treatment, and the first choice oxybutynin. If there's no benefit, then you can use, before you move to another drug, you can increase the dose. And if with the maximum dose there's no benefit, you can move to another drug like daraphenocin or sulfanicin. The trade name of this is Visicare. Women should be counseled regarding the adverse effect of it. Before you start, you have to explain the side effects, otherwise women will not tolerate it. Systemic HRT should not be recommended as a treatment for stress incontinence, but you can use HRT if you have other symptoms with the overactive bladder. Overflow incontinence and voiding difficulty causes is neurological, myogenic, iatrogenic, obstructive and inflammatory. Diagnosis, clinical suspicion, ultrasound, catheterization. Management, catheterization. Leave the catheter for 2 days, then try without catheter. If retention still there, then you use suprapubic catheter for 2 to 6 weeks. Bethanechol 25 mg TD 3 times a day, surgery, and that's it. Thank you. That's it about the lower urinary tract evaluation. Okay.